I'm presenting an electronic poster on the post-marketing surveillance of Rivaroxaban. What this is a safety evaluation of Rivaroxaban post-approval by the FDA. And what that is that we looked at about 40,000 people to date. The number is 39,000, but I'm going to do round numbers. And we looked at how often they bled and what the consequences were. Rivaroxaban is an anticoagulant. If, anticoagulants do what they're supposed to do. They're blood thinner, they make you bleed, increase the risk of bleeding, and so we wanted to determine if that was consistent with the existing published studies. When you do a randomized controlled trial, you have a very defined population of people with a certain age and a certain risk factor profile that's well described. When you roll it out to the public, so all doctors anywhere can use it, you're not always certain that they're going to apply it right, and that risk-benefit analysis may change. And so the purposes of this was to define exactly what the risk was, or the bleeding consequences of Rivaroxaban. What this is to make sure there's not any surprises. 40,000 people is as big as a town. That's bigger than any trial that has been done. And the point of that is because sometimes, when drugs roll out, there are strange little things that happen. We didn't find any strange little things. So that was good, and we wanted to make sure that the results that we have in real life look like the results that we had when we studied it in a randomized controlled trial. We did about 40,000 patients. 970 of those folks had a bleed. Overwhelming majority is it's a GI bleed, about 85% of the time. About 35 died ultimately. Most of those had intracranial hemorrhages. The bleed rate was about 2.89 per 100 patient years of exposure. We measure this for 15 months, so you can do the math on that. So 2.89 per 100 patient years will have a bleed. The risk of dying from that is 0.1 per 100 patients a year. This is all statistically consistent with what we saw in the original trials, and it also goes to show you that these drugs are inherently safe. The point of an anticoagulant is it's somebody who has a problem of clots. So they're either having clots in their legs or clots in their lungs, or their hearts are throwing clots around and they're having strokes, but they got too many clots. And there is always a balance between clotting and bleeding. And so a person whose pendulum is on the clot side, you have to give them an anticoagulant. You have to thin their blood. The question is does that pendulum swing too far? And so it's really a risk-benefit analysis of danger of clot, danger of bleed, and making that pendulum get in the middle somewhere. And so I will tell you that the data that we have now is it's clearly safer to be on anticoagulant, on Rivaroxaban, than it is to not. And it is safer, or at least no greater risk of bleeding than the historical standard. The other thing that's interesting about all these drugs, all the class of the oral anticoagulants other than Coumadin, is that they have a decreased risk of intracranial hemorrhage, a slightly increased risk of GI bleeding. But when you look at the big picture, if you give them the choice, you pick a GI bleed. Because I'm an emergency doc, I know how to deal with GI bleeding. I put some fluids in you, maybe I give you a blood transfusion, your drug wears off, we're done. With intracranial hemorrhage, bleeding into your brain causes brain damage. I can fix the anticoagulation problem, but now you have brain damage. And if you look at the numbers on that, about half the people who get intracranial hemorrhages will end up dying that visit. So it's a disaster to have an intracranial hemorrhage, and it's a nuisance to have a GI bleed. And so, and the data clearly supports this, is that when you have both events, you pick the GI bleed, and the fact that there are slightly more GI bleeds with any of the oral anticoagulants is a safety plus. In terms of that pendulum being too much clotting, too much bleeding, it's where it needs to be, because it's the safety side of preventing clotting, but not resulting in excessive risk of bleeding to death. So 40,000 patients followed for 15 months with a bleeding profile that clearly favors the risk-benefit analysis. I think it's pretty compelling evidence, especially when you consider the prior randomized controlled trials that demonstrate safety and efficacy. So I will tell you this, that there was a meta-analysis done by Christian Ruff, 75,000 patients roughly, that showed that you are safer on an oral anticoagulant, a new oral anticoagulant, without an antidote than you are with the old anticoagulant, Coumadin, with an antidote. So as a doctor, you have a decision. You want the old stuff with a higher death rate or the new stuff with a lower death rate? And I don't think that's a very difficult decision. The new oral anticoagulants represent a series of drugs. The first was dabigatran, it's a direct thrombin inhibitor, followed by Rivaroxaban, a factor Xa inhibitor, edoxaban, and apixaban. And there's others in the wings that are going to come out as well. But the whole as a class, the new oral anticoagulants, all have decreased rates of intracranial hemorrhage, slightly increased risk of GI bleeding, and overall, as a group, a lower risk of death. So it's sort of a no-brainer.